like a heart monitoring lead. You can see down here, this is the sticker that they place on the chest, and then there's a similar lead on the left side of the chest wall. So no tubes. So apart from the esophageal atresia, is there anything else that you see?
Excuse me, Toby, what kind of, you are using the pointer? Or
yeah. Can you see it?
Can you move it, because I cannot see it right now?
Can you see it now?
I can see it now.
Okay. So sorry, I was saying that this is the this is actually the sticker for an ECG lead here. So this is just an ECG lead rather than a vascular line. And then you can see there's a similar appearance on the left chest wall. And then this is the NG tube as described, coiled in the proximal esophagus in keeping with esophageal atresia. What else about this radiograph? What's the other feature on this radiograph related to the esophageal atresia, candidate 3?
I see there is gas in the stomach bubbles, I see. So I'm going with tracheoesophageal fistula. Tracheoesophageal fistula. I think this is type C, with the proximal esophageal atresia and distal tracheoesophageal fistula.
Okay. So we don't tend to type on the chest radiograph, but by the fact we've got a proximal esophagus, that's where the NG is coiled. You can have a hazard as at the guess of the type. But yeah, you're completely right. The presence of gas in the stomach suggests that there's a fistula between the trachea and the distal esophagus. And then this is what's letting gas enter the stomach. So we'll just move on. So once you identify this on the chest radiograph, what else would you be looking for? So this is a different patient, which shows who also has esophageal atresia. So once you've made this diagnosis on your chest radiograph, what else are you going to assess on the radiograph?
Is this an infant babygram of immature infant? I didn't see is a ossification center, ossification of upper limb. I see there is two line as umbilical arterial caster, which is going through the chest. I think it's proper position above in the correct position, upper end.
What's the correct
also
position?
I see the venous caster, umbilical venous caster, which is going to the right.
Between the trachea and the distal esophagus, and then this is what's letting gas enter the stomach. So we'll just move on. So once you identify this on the chest radiograph, what else would you be looking for? So this is a different patient, which shows who also has esophageal atresia. So once you've made this diagnosis on your chest radiograph, what else are you going to assess on the radiograph?
Is this an infant babygram of immature infant? I didn't see is a ossification center, ossification of upper limb. I see there is two line as umbilical arterial caster, which is going through the chest. I think it's proper position above in the correct position, upper end.
What's the correct position?
Venous caster, umbilical venous caster, which is going to the right, seen in the portal vein. I think it is due adjustment. It is proper position for here. I didn't see any
just before you move on, candidate 3, what are the correct positions for the umbilical arterial catheter and the umbilical venous catheter for those who don't know in the audience?
The umbilical arterial catheter should be seen in the area. There is two position, high level and the lower level. Okay. High level usually should be above D10.
Yeah.
Lower level should be just below number 3 vertebral level, to be away from renal arteries origin.
Yeah.
For umbilical venous caster, I see it is should be adjusted to going to the junction of the inferior vena cava and the right atrium to position. I see it directed to the right hepatic vein could be in the right portal vein branch.
Okay, that's correct. Okay, sorry, carry on assessing the radiograph.
For this radiograph, I doesn't see any gas bubble, any gas shadow in the abdomen. So and also I see there is some linear tubular structure in the upper part of the esophagus. So I am going with this esophageal atresia, complete esophageal atresia without fistula.
Okay. So once you've made the diagnosis of esophageal atresia / tracheoesophageal fistula, there are other things that you're assessing for to make another diagnosis. What other things do you think you may be assessing the radiograph for?
I think was going with syndromatic syndrome. I think it's faces or bacterial.
Okay. So what things can you assess as part of bacterial on this radiograph?
And bacterial, okay. I am check V for vertebral anomaly.
Okay. So do you see a vertebral anomaly?
I search for here.
Okay.
I see vertebral limb. I see some could be some rheumatic upper limb. The E for arterial. C for cardiac anomaly. I see could be for cardiac palpitation. T for tracheoesophageal fistula. Don't remember the rest actually.
Okay, that's fine. I'll tell you about the rest. So, so in cases of tracheoesophageal fistula, we have to assess for something called bacterial, which is a syndrome, because esophageal atresia and tracheoesophageal fistula are associated with other anomalies, developmental anomalies. So on this radiograph, we can see a couple of them. So V is for vertebral body. So we're looking for any vertebral body anomalies such as hemivertebrae, fused vertebrae, and things like that. And you can see here at the sacrum that there's abnormality at S3, 4, and 5. So you've got what looks like S4 fused to S3 with only half the vertebral body present at S4. So it's probably a hemivertebrae that's fused to S3. We can also, anorectal malformations are associated, so that's the A in bacterial, and that's often diagnosed clinically by the surgical team or the neonatal team when they do their baby check. And then C is for cardiac, so we can look to see if the heart appears enlarged, suggesting that it might be an underlying congenital abnormality. In this case, the heart is enlarged and the child actually ended up having tetralogy of Fallot as well, which in the UK we call this. If you have tetralogy of Fallot with a tracheoesophageal fistula, then we call it a double TOF, given the abbreviations. T is for tracheoesophageal fistula. So on this, we can see that there's no evidence of bowel gas in the abdomen or the stomach. There's no gas in the stomach, so there's no obvious fistula up here in this patient. O is for the esophageal atresia. O, it should be O, but it's an E because it's an American spelling, which is for esophageal atresia. So here we can see we've got a repulsor tube in the proximal esophagus in keeping with an esophageal atresia. R is for renal. So all these patients will have renal ultrasounds to assess for any renal abnormalities such as horseshoe kidneys, duplex kidneys, unilateral kidneys, single kidneys, etc., etc. And then L is for limb, and as correctly identified, you can see here that the patient is missing both their radial bones bilaterally, and the upper limb, the forearm appears shortened. So this child has limb abnormalities as well, which is what the L in bacterial stands for. Can everyone hear me clearly, or is the sound not clear? I've got a message that someone can't hear me.
I can hear you very,
Okay.
very clearly. So the problem might be at the end of the person who has posted that. Please continue.
Okay, perfect. So there's lots of different types of esophageal atresias, as candidate 3 said. And basically, esophageal atresia is where you get a congenital occlusion of the proximal esophagus usually. And it's thought that it's due to faulty division of the foregut when it differentiates into the trachea and the esophagus, and it usually happens very early in the first trimester of gestation. From this faulty division, you can also then get a tracheoesophageal fistula, which is where you get a fistulous connection between the trachea and the distal part of the esophagus. And you can either get a single connection or you can get multiple connections. And we will see that evidence in the radiograph by gas within the stomach and the bowel. So if there isn't a fistula present, we don't see any gas. If there is a fistula present, we do see gas. And sometimes in a H-type esophageal atresia, you don't actually get a true atresia. All you have is a tracheoesophageal fistula. So that's a H-type fistula. And this is demonstrated on this image. And then the other thing to say is that the level of the fistula can be variable, but it's normally in the region of the carina. And how the gap between your atretic segment and your distal segment can also be variable, and it can be as high up in the neck, or it can be lower down in the mediastinum, for example. So sometimes the surgeons aren't able to do a primary anastomosis, and they have to use a conduit such as the stomach or the colon to anastomose and make a neoesophagus. So we've looked at the radiographic findings already, so I won't repeat them because I think I've said them many times already. So we've seen the chorodenteric tubes. We can also sometimes see a thing called a repulgal tube. So that is a tube, I'll just show you the picture of it. So this is a repulgal tube here. Sorry, my pointer's gone. Put it back on. This is your repulgal tube here. And basically it's a double lumen tube, and it goes into the proximal pouch and it drains the proximal pouch. So it shows, it helps because the patient will be swallowing their secretions all the time, so they need to have that drained. So that's what the repulgal tube does. It just drains that blind ending atretic segment. And it's either inserted orally or nasally into the patient esophagus. We don't do contrast studies to look for, to diagnose esophageal atresia. It's normally done clinically, and sometimes it's even diagnosed antenatally, and it's done clinically on presentation. They can't pass the NG tube, and then they do a radiograph, and then that confirms the presence. But we do sometimes do contrast studies either to look for H-type fistulas, particularly in kids who get recurrent aspirations or have any difficulties with recurrent chest infections, and they think that they might have a hidden H-type fistula. Or we do it post-repair. So prior to them feeding the patient, we'll do a fluoroscopic study. Let's see if that shows up, to look to see if there's any evidence of a leak at the anastomotic site prior to them feeding the patient. So what we'll do then is we'll gently withdraw the in situ NG tube, which they leave post-operatively, and then we'll put some contrast down and see if there's any evidence of a leak. This image actually shows, I don't know why my pointer keeps coming off. So this image actually shows a fistula. So you can see here, this is your connection between your esophagus and your trachea, this little tiny bit of contrast that's extending between the two of them. And this is kind of the subtle things we're looking for trying to diagnose the H-type fistulas. With an esophageal atresia, the children will end up having esophageal dysmotility, so they'll have dysphagia. Some won't be able to swallow certain solids, and we'll sometimes do contrast studies just to assess the dysmotility, and also look for things such as gastroesophageal reflux. And they can also develop strictures down the line at the site of the anastomosis. So we'll sometimes do a contrast study to diagnose this, and then they'll go on to have serial esophageal dilatations for the stricture. So Bacterel as...
Excuse me, Toby,
Yeah.
there are some marks on the screen. Do you know how to done it? If you can undo it also. So in any case, let's continue.
Okay, give me 2 seconds. I've somehow turned subtitles on, so I want to turn them off. Okay. So Bacterel is a syndrome that's associated, that esophageal atresia and tracheoesophageal fistula are associated with, and it's often due to chromosomal anomalies. So frequently you see it in patients who have trisomy 18 or trisomy 21. And the associated anomalies are vast for each letter. So vertebral anomalies include hemivertebrae, like I said. They can have a scoliosis. They can have caudal regression, which is where the spinal, the conus terminates high, and they will often get sacral anomalies with that. They can get rib anomalies. They can get tetralogy of Fallot and dextrocardia. they can get distal atresias in the small bowel, they can present with malrotation. So there's an endless list of different abnormalities that are associated with this. And basically what we're doing is we're trying to assess the patient to pick up as many of these as possible. And the initial radiograph is really crucial because it will pick up your vertebral anomalies, it can pick up your cardiac anomalies if you see an abnormal cardiac contour or cardiac enlargement, and it can also pick up your limb anomalies. So you've really got to interrogate them. If they show you this case in an exam, you need to make sure that you're looking for all these other signs. I just wanted to mention about the UVC and the UAC. Neonatal chest radiographs tend to have multiple lines in situ. So as candidate 3 did there, you need to assess the lines and check the positions first before you then go on to present the pertinent findings in the chest or abdomen. So we're moving on to the next case. So candidate 3, do you want to have a go at this case? The findings are subtle, so if you don't get it, don't feel too bad.
Okay, yes. I provided a frontal sonograph of immature infant. I see there is nasogastric tube passing to the gastric component region for stomach. I see multiple dilated bowel loop in the center of the abdomen. In the right hypochondrium, I see there is some mottling of bowel loop at the wall. I don't see any pneumoperitoneum. I don't see any intramural gases. So I am worried about small bowel obstruction, necrotizing enterocolitis for the patient.
Okay, perfect. And then we're going to move on to, this is a different patient who's presenting acutely unwell on the neonatal unit. So it has a abdominal radiograph. What do you see here?
In this frontal radiograph, I see there is bowel dilatation, as well as I see there is intramural lucency in the wall of the bowel going with pneumatosis intestinalis. I see there is also gas going to the portal venous portal vein to the peripheral hepatic region. So this is a portal venous gas. So this is a case of necrotizing. I don't see any also pneumoperitoneum in this study. Don't detect it. So this is a case of necrotizing enterocolitis complicated by pneumointestinalis and the portal venous gas.
Perfect.
This is a surgical emergency.
Okay, perfect. I'm really sorry. You can hear beeping because I'm on call as well. So I'm trying to deal with some queries whilst I'm teaching, but you now have my attention again. But what you said exactly was correct. So I'm just going to go back to case 1 and say, so necrotizing enterocolitis can have very subtle findings on plain film. So I'm showing you a case of a subtle case and then a more florid case, which is the second case. So lines and tubes, you did again, which is, like I said, we have to look at those first because a misplaced line or tube can have its own complications. And then here we can see in that right side of the abdomen that there's some subtle bowel wall thickening, which is a non-specific sign for NEC, but necrotizing enterocolitis, but it's important to mention it. What I also look for is over a series of radiographs. If this child had 3 abdominal x-rays and they all look like this over a period of the day or 2 days, and the bowel gas pattern wasn't changing, that to me suggests that there's sluggish peristalsis, the bowel is not happy, and that also raises the possibility of necrotizing enterocolitis, even if I don't see all the other findings that I would typically see. So speaking of typical findings and things that demonstrate NEC, so we can see here, as candidate 3 described, you have linear branching lucencies over the liver shadow, and they reach to the capsule of the liver, so they reach all the way out to the periphery, and this is in keeping with portal venous gas. If this was biliary gas, it wouldn't reach all the way out to the periphery, it'd stay more central, so that's how you can differentiate between the two. If the patient had a UVC, umbilical venous catheter in, and I saw it was misplaced, like we saw in an earlier case where it was in the liver, and I saw portal venous gas, then I would more likely put that down to the misplaced UVC rather than necrotizing enterocolitis. But it's just an important point to have as a differential when you see portal venous gas. Is there a misplaced umbilical venous catheter? And then we can potentially see that there's possibly some areas of pneumatosis, although it's not super florid on this radiograph. And the other thing we're looking for is perforation, so any evidence of pneumoperitoneum, because these children are at risk of perforating these necrotizing enterocolitis. So what is necrotizing enterocolitis? Well, it's normally present in a very low birth weight or premature infants. And in the UK, we're now seeing babies going into the neonatal intensive care units at 22, 23 weeks. So these patients are under a kilo and they're at very high risk of developing NEC. We do sometimes see it in term infants who have underlying other conditions that put them at risk of getting GI tract inflammation and ischemia. And what happens is they get inflammation of the bowel and they get translocation of bacteria into the bowel wall. And then they also, from the inflammation, it affects the blood supply and they can have ischemic changes, which we see as pneumatosis, so air within the bowel wall. Radiographs, like I said, it can be non-specific, so we can see anything from a gasless abdomen to distended bowel loops to a non-changing bowel gas pattern. So just because you don't see the classical diagnostic signs of pneumatosis, portal venous gas or pneumoperitoneum, you can never fully exclude NEC on an abdominal radiograph, and it's important that you make the clinicians aware of that. Also, there are some things that are suggestive of NEC, which might raise the concern, particularly if you're reporting a radiograph of a premature infant, such as a thickened or dilated bowel loops. And like I said, a non-changing bowel gas pattern over a series of plain films always makes me raise the flag to say, could this be NEC? Most commonly, we see it changes in the right lower quadrant. I'm not exactly sure why, but that tends to be the most common site, but we can see it anywhere along the bowel. And it's normally managed conservatively. So they put the child on bowel rest, so they'll switch them to total parenteral nutrition, so IV feeding. They'll put an NG in for comfort if the bowel is distended to try and aspirate some of the gastric contents, and they'll start them on IV antibiotics to treat the infection/sepsis. If the child does not improve despite all the conservative treatment, or if they develop any signs of obstruction or perforation, then they'll tend to go for surgery. But you try and avoid surgery in these children because surgery comes with its own complications, and then they've got the potential for generating adhesions and so on and so forth down the line, which will lead to bowel obstruction. So we can do ultrasound to look for NEC. In the UK, we tend to use it as an adjunct rather than the first line imaging, which is still plain films in combination with the clinical history. But there are certain signs that we can see on ultrasound like we see on the plain film. So first of all, we can see pneumatosis. So here we can see, so these are loops of bowel, and you can see air is echogenic on ultrasound. So we can see multiple echogenic foci around the wall of the bowel, which is in keeping with pneumatosis intestinalis. And here we've got another more florid example here. What we can also see is we can see a paucity of peristalsis. So what I tend to do is when I'm scanning these neonates, I put the probe on and I leave it there for a few seconds and just watch the bowel and see what the bowel does. Does it move? Is it sluggish? Or is it actively peristalsing? And if it's sluggish or aperistaltic, then I'll raise the potential that this could be related to NEC. We can also assess for bowel wall thickening. So I use about 2 millimeters as my standard for normal bowel wall thickness. So anything above that suggests that the bowel is, as I like to say, unhappy and thickened. And then we can also assess for vascularity. So we'll see a paucity of vascularity in the affected bowel loops and in the mesentery supplying the bowel. Other things we can look for are, portal venous gas. So if you put your probe over the liver, you'll see little echogenic bubbles floating through the portal venous system. And if you put a color Doppler on, I don't have an image to show you, I don't think, but if you put a color Doppler on, you'll actually see a little artifact of spiking on your portal venous trace, and that's because of the air bubbles going through the vein and affecting the Doppler. We can also look for free intraperitoneal air. So I like to look along the liver capsule to see if I can see any echogenic foci, which is in keeping with free air. And we also can look for focal collections or echogenic ascites, so free fluid which looks dirty with multiple echoes, which suggests that there might be a perforation. So ultrasound can be used to further assess, but it's really done kind of as a to look for a child who's already on treatment to see if things are progressing rather than to make the initial diagnosis. So we're going to move on. I think it's still you, candidate 3. I'll do the questions at the end. So candidate 3,
okay,
do you want to have a look at this X-ray?
Okay, this frontal chest radiograph of immature child, mature infant. The first I see the nasogastric tube in the saying go to the stomach gas bubble, so it is normal position. Also, endotracheal tube C in proper position just above the carina. There is, I think this there is central venous line, intravenous jugular line passing from the left internal jugular to the right side. The chest radiograph and other for me, is this intravenous line? Okay, I think it's proper position also. I see there is central rounded lucency in the abdomen. So I am more about the pneumoperitoneum.
Yeah.
For the patient.
Okay, so that's this case. And then do you want to do this case?
Okay, in this case, I see there's dilated nasogastric tube C in normal position. I see there is multiple dilated bowel loop with some in the right side of the abdomen and the pelvis, some mottling or bowel feces sign.
Yeah.
So I'm worried about bowel obstruction.
Okay.
I don't see any portal venous gas, any intramural gas, not clear for me.
Okay.
For this one. Since I think this is bowel obstruction for the young age, it is necrotizing enteropaths also. I don't see any other pneumoperitoneum or something perforation.
Okay, and then this is the final one. So what do you see?
In the second one, I see there is marked free air in pneumoperitoneum. I see there is a dilated bowel, small bowel loop with regular sign seen both sides. This is I see this tube.
Okay, so you've seen 2 with pneumoperitoneum and 1 that's NEC/bowel obstruction, but no pneumoperitoneum. So let's just go back through them. So all the lines and tubes are in the right place. So the central venous catheter tip, it's a bit low. It's at the right atrium. It should be at the cavoatrial junction, but I'll allow it. ET tube and NG tube are correctly sited. So as candidate 3 said, there is this rounded lucency over the visualized abdomen. So what this radiograph is basically showing you, is if you ever get presented it in an exam, is that initially you're like, it's a chest radiograph, I need to focus on the chest. But don't forget to look outside of the chest and to look at the periphery of the film, because the abnormality might actually be there. So this is actually a football sign, which is incompletely imaged because we don't have the whole abdomen on, but this is seen in pneumoperitoneum. Moving on to the next case. So here we can see the mottled lucencies suggestive of NEC, and there is no portal venous gas, you're correct, and there's lots of dilated loops. But up here, you've got this weird lucency that's triangular in the upper abdomen. And this is where your pneumoperitoneum is. So the bowel does not make triangles. So if you see triangles of air in an abdominal radiograph, it's pneumoperitoneum until proven otherwise. And then you can do a lateral shoot through. So either turn the patient decubitus and image them that way, or shoot through the side of their abdomen and you look to see air at the upper part of the abdomen, like Sam showed in one of her earlier cases. I'm just going to go back to this. So this here, if you follow my pointer, this lucency in the abdomen is abnormal. So this is the pneumoperitoneum. So it should normally, it's called a football sign. So it looks like a rounded ball of gas, basically, which is sitting at the top of the, underneath the anterior abdominal wall. So this is your abnormality here. So this pneumoperitoneum, this triangle of gas here is your pneumoperitoneum. So you can also see that there's no bowel wall around this. gas. Like, so you can see here, you can see bowel wall around and here, but there's nothing around this bit. So this tells you that this is pneumoperitoneum. And then finally on this case, this shows a continuous diaphragm sign. So if we look very closely at the diaphragm, it looks like you can see the entirety of the diaphragm, even across the midline, which we don't normally see. And that's because you've got air on both sides of the diaphragm. So sign, and we've got this triangle of gas here as well. See here, like, remember that I said bowel gas does not form, intraluminal bowel gas does not form triangles. So if you see a triangle of gas, you've got to raise the concern for pneumoperitoneum, and you can further confirm that with a lateral shoot through. Other lines that you may not be familiar with, so this is going to be a urinary catheter line here, and then I think that's it, and we've got the NG tube, and that's it. So these were all 3 cases of pneumoperitoneum, which can happen as a consequence of NEC, but also bowel obstruction, like Sam said, with atresias, etc., etc. So on the radiograph, we're looking for lucency overlying the liver. It also will then accentuate peritoneal ligaments. So you can see, sometimes you'll see the falciform ligament in the liver outlined by the gas. You'll see the football sign, which we saw on the first case, which is an oval hyperlucency, which sits underneath the anterior abdominal wall. And that's because you've got such a large volume of gas, it just rises and sits underneath the abdominal wall. You'll see triangle sign, which is pockets of interloop gas, which we've seen on 2 of the cases, and wriggler sign, which is where you see both sides of the bowel wall. The catheter in the previous image was a urinary catheter, so into the bladder. And we can do a lateral projection, like I said, so either a horizontal beam where the machine and the detector are at the sides of the patient, and you shoot the beam through the patient whilst they're supine, or if the patient's stable enough, you can actually turn them onto their side, hold them there for a few minutes, and do a lateral decubitus radiograph, which is the most sensitive. And what you'll see on that image is that you'll see the air rising above the abdominal contents to sit underneath the abdominal wall. If you see peritoneal calcification on a radiograph, particularly in a neonate, it suggests antenatal perforation, so due to an atresia, like you saw in Sam's earlier cases. So this is just another example to show you a football sign. So this, if we had a proper abdominal radiograph on that earlier case, this is what you would see, this big lucency, and you can see that there's bowel loops in the abdomen, but there's this massive amount of free intraperitoneal gas. And then this is outlining the falciform ligament in the liver, just here. Okay, and then this just shows you the wriggler sign and that continuous diaphragm sign and that interloop pocket of fluid, as I've already mentioned. So we're going to move on to the next case. I don't know if I'm switching candidates or not, but maybe I'll give this last one to candidate 3 and then we'll change. So do you want to have a go at this case, candidate 3?
Okay. I have 3 images of ultrasound abdomen showing the pyloric canal of the pyloric canal. There is measurement in the for me left one. I see the thickness of thickness of the pyloric wall about 0.34 34 millimeter. The length of the canal about 2 centimeter. It is dilated. In the other view, I see the thickness also here, measuring the total caliber and the length. So this all thickness of pyloric wall more than 3 millimeter, suggestive of congenital hypertrophic pyloric stenosis.
Yeah, perfect. So this that's exactly the case. So this is a case of hypertrophic pyloric stenosis. So here we've got the pylorus, we've got the stomach, which is, you can't see it fully on this image. This is pancreas, and then this is liver. And the pylorus normally sits between the pancreas and the liver, so I use that as my landmark for when I'm looking for them on ultrasound. And this will be a LS view, so a long view of the pylorus. And we can see that the single muscle thickness, so if you measure just the hypoechoic muscle to the edge of the hypoechoic region, is over 3 millimeters. The length of the pylorus itself is elongated, as Candidate 3 said. And then when we do it in transverse, we get this donut sign here. The other things that I want to point out was with pyloric stenosis is when you're doing the ultrasound, often people will mistake the esophagus for the pylorus, and because you normally see the esophagus coming in here and heading towards the stomach. So if you can follow the structure into the chest, that's going to be your distal esophagus coming through your diaphragmatic hiatus. That is not your pylorus. You should be looking for your pylorus between the liver and the pancreas. And then what we should also be doing is trying to do a dynamic assessment. So I normally just put my probe on and watch to see if I can see the pylorus open. Normally you'll see that the stomach is distended with lots of gastric contents, and the pylorus won't open. So normally you'll see here, it should open, it should separate, and then you should see stuff passing into the D1. Sometimes I'll try and trigger this, so I'll give the child a feed, either water or milk or whatever. I'll ask them to give the child the feed either via the NG or orally, and watch to see if the pylorus opens, because that dynamic assessment really tells you is there a true stenosis, or is everything due to pylorospasm, which I'll come on to. So this is an example of a normal pylorus, just for you to contrast to the abnormal. So this hypoechoic band here that you can see on both sides is the muscle, and that is what we're measuring. So just this hypoechoic structure here, and that is what becomes thickened in hypertrophic pyloric stenosis. So the single muscle wall thickness should be less than 3 millimeters, and this is the most accurate measurement, this one here, for pyloric stenosis. Normally, the transverse diameter, so that's if you measure across the entire pylorus, should be less than 14 millimeters, and then the pyloric channel length should be less than 15 millimeters. Some papers will say less than 17 millimeters, and I even read one paper that said less than 12 millimeters, but 15 millimeters is the most commonly accepted measurement for the length of the channel. And like I said, you can see that the pylorus should open on dynamic assessment for it to be a normal study. So this just shows you the measurement. So this is the trans diameter. So you can see that this is 11 millimeters, which is within normal. The single muscle wall thickness is 1 millimeter. And then I've not got a channel length measurement, but that was also normal. So this is our case that we saw. We can see that the muscle wall is too thick, so it's more than 3 millimeters. The channel is too long, so it's 21 millimeters rather than being less than 15. And the transverse diameter is not measured here, but this would most likely be more than 14 millimeters. And then this is another case to show you the thickened muscle wall. This is slightly over measured, but it's probably about 5 millimeters and 18 millimeters. Someone's asking, should the transverse diameter be measured without gastric content passing through the pylorus? I'm not too sure about that question. Because in a true pyloric stenosis, you won't see any gastric contents passing through the pylorus. And the transverse diameter, I don't tend to measure on the transverse image. I tend to measure just on LS, and I just measure those three. Transverse diameter should be less than 7 millimeters. No, so the transverse diameter is across both. Oh, sorry, yeah, it should be less than 7 millimeters across both the wall. Is that what you're saying? I'm not sure. But it's the measurement from one wall across the middle and then across to the end. And yeah, sorry, I think that is a typo. It should be less than 7 rather than 14. Oh no, each wall is 3 millimeters. I'll come to you at the end because I think I'm interrupting what I'm saying, answering your questions. And I'll double check the measurements to see if we've put a typo in. And then on the rounded view, on the transverse view, I don't tend to measure the wall on a TS view. I tend to measure it just in the LS view, but you can still see that the muscle is more than 3 millimeters. So I just want to think I've got a video somewhere. So this was a case that I did a few months ago where the muscle thickness is borderline. So you can see it's 2.5, so it's coming to the upper limit of normal, but it looks like what I would expect a pyloric stenosis to be. So all the measurements were just borderline going to the upper limit of normal, and the patient had a really convincing history of vomiting. And I think their gas was slightly off as well. They had a bit of metabolic alkalosis. But because it was borderline and I didn't see it open during the study, I really wanted to bring the patient back to confirm whether what I was seeing was truly pyloroxenosis or just due to spasm, pylospasm, because the child was upset and things like that. So I scanned them a few days later, so like a day, I think it was 2 days later, because they were clinically stable, and you can see that the muscle wall thickness is actually normal. And what we were seeing on the initial radiograph, on the initial ultrasound, sorry, was just due to pylorospasm, and I saw it open on the follow-up X-ray ultrasound. So here we can see it looks more normal than it did before. So you can compare the trans to the trans views. I thought I had a video, but I don't think it's playing. So we'll just go on to the next case, which is case 17. So do we want to change over? Is there a fourth candidate?
So candidate 4, are you with us?
Yes.
Over to candidate 4. Toby, thank you. Over to you.
Okay, so do you want to present this case?
Yeah, sure. Yeah. These are the selected images of the ultrasound of an abdomen. I can see on the left side there's a target sign, which are comprised by the bowels, and on the right, upper and lower, I think this indicates a pseudo kidney sign.
Mm-hmm.
So these are most likely to represent intersusception.
Yeah, correct. And then we'll move on. Okay, so as candidate 4 correctly spotted, we've got, so this is an ultrasound with the probe in the right upper quadrant. So this is your liver here. And we can see that we've got this, this is a transverse view. So we've got this rounded hypoechoic and then centrally hyperechoic structure, which is in keeping with our target sign that we see in intersusception, which I'll come on to explain. And then here we've got a LS view. So we've elongated out this structure and we can see the pseudo kidney sign. So here we've got a hypoechoic periphery and central hyperechogenicity, but we know it's not the kidney because we've got the kidney down here. So this is a pseudo kidney sign, and this is also a pseudo kidney sign, which I'll come on to explain. So the donut sign is because you get concentric alternating bowel wall layers. So you get the mucosa and the muscularis, and then you get hypoechoic bands. So the mucosa and the muscularis are echogenic, and then you get hypoechoic bands, which are the submucosa. And then that's what you see here. So you get alternating bands. You can see hyperechoic, hypoechoic, hyperechoic, hypoechoic, and then you get centrally in the middle, you get that mesentery that's been pulled in. And then with your pseudo kidney sign, you get a mimicker of a kidney. So basically the mesenteric fat centrally mimics the fatty hilum, and then the bowel wall mimics the cortex. And that's why it's called a pseudo kidney sign. And then as long as you see your kidney, you know that's what you're looking at, or you turn TS and see this donut sign. So what we're looking for is, can we see any complications that will be contraindications to doing a radiological reduction? So we're assessing for vascularity. So I always put color Doppler on to see flow, and there should be flow in the mesentery and flow in the bowel wall, as we have in this case. I also look to see if there's any fluid within the intersusception, because that can make it a bit more challenging to reduce, or can suggest that there's a lead point such as a duplication cyst. I look for free intra-abdominal fluid because that can be due to perforation. And I also try and assess for a lead point. So often in these intersusception patients, it's because they've had a viral infection of some sort. They've got enlargement of their lymph nodes, and the mesenteric lymph nodes act as the lead point. So you'll see mesenteric lymph nodes such as this within the center of the intersusception mass. Other lead points you may see are polyps or duplication cysts, like I said, or even a Meckel's diverticulum. And you may not see them on the initial ultrasound, but if you have patients who present recurrently with intussusceptions, or you have older children presenting with an intussusception, then just be aware that there might be a lead point. So this is just another picture to show you an intussusception. And then this is another picture as well. And here we can see it nicely shown. You can see this is the intussusception with the alternating layers. Play. This should play. Let's see if I can make it play. Oh, okay. My video is not playing, unfortunately, but this was just showing you an intussusception on a video. It's not super exciting, so you're not missing out on anything. Okay, sorry, everything froze for a second. Okay, so that's ileocolic intussusception, and that's the most common type of intussusception we see, and that's the one that requires reduction. And I'll come on to reduction in a second. What we can also see is a small bowel, so ileo-ileal intussusception. And these can present in a similar way with colicky abdominal pain, child drawing up their knees, but they don't tend to present with the PR bleeding. So with the jelly-like stools that you see. So often when you're scanning, you can see a small bowel intussusception in the paraumbilical region on the left side of the abdomen where you've got lots of ileal or jejunal loops. To help you differentiate between that and an ileocolic, normally the diameter on the AP, so on a transverse anterior to posterior measurement, is less than 1.5 centimeters, so they're smaller, and normally they're a shorter segment, and the hypoechoic wall is thinner because the small bowel wall is thinner than the colon wall. You will still see the mesentery centrally, but you won't tend to see lymph nodes within them, which helps you differentiate. And normally, even as you're scanning, they will disappear. So you'll scan, you'll see it, you'll take your images, you'll scan something else, you come back to that area and it's disappeared, or it's in another different part of the bowel. And these ones, small bowel ones, do not require a reduction. So if you see a small bowel intussusception, you can just say it, tell the surgeons, but they don't require a reduction. Sometimes we'll repeat the ultrasound to make sure that they've resolved, or we'll repeat it if the patient's not clinically improving. So moving on to intussusception. Trying to make my videos play. I can't play my video. Oh, here we go. I just saw a thing flash up. Are we going to play? I can't make my videos play, but what I'll do is at the end, I'll get Sam to put up her slides and we'll play the videos from her computer. So what we do in my practice is that we do an air enema reduction, so a pneumatic reduction. Some centers do a water enema reduction, but I think I and Sam, we both do pneumatic ones. And what we do is we do it under fluoroscopy, so we have real-time X-ray guidance because there's a risk of perforation. And so we put a catheter into the rectum. So I try to use as big of a one that I can fit in. So a 16 French is usually what I go for. And I put it into the rectum. And you can either do it with the patient supine or prone. I tend to do them prone because it means you've got some pressure on the abdomen and it helps maintain your intra-abdominal pressures to help your reduction. But some people do it supine. You have to keep the catheter in the rectum, so you either put a finger against the catheter at the anal verge, or you can inflate the balloon with a small amount of water, and then you insufflate the bowel with your air generating machine, whatever that is. And we normally do 3 attempts up to 3 minutes. We're starting with pressures at 80 millimeters of mercury, going up to 100 on the second attempt, and then on the final attempt we'll go up to 120, but some centers do 100, 120 for all 3 attempts, so it depends on what you do in your local practice. If I'm getting close and I'm on my 3rd attempt and it's coming to 3 minutes, I may go for a little bit longer, but generally 3 attempts up to 3 minutes is what is recommended. And you've got to continuously screen as you're insufflating the bowel because there's a risk of perforation. The other risks are you can not reduce it, which we can see sometimes. Sometimes you can get it to the ileocecal valve and you can't get the air into the small bowel, but the surgeons will still appreciate that because you've pushed it round for them. And then there's also a risk, I think it's about 10% of them recur post-reduction. So when the patients are consented by the surgical team, they need to consent for all of those things. I also get them to consent for bruising on the buttocks because you're squeezing you're getting someone to squeeze the buttocks to maintain your pressures, and that can cause bruising. Contraindications to doing air enema reduction include any features of perforation on the ultrasound. So if you see any mucky fluid or you see any free gas over the liver capsule, then that's an absolute contraindication. If I see ischemic looking bowel, I also won't attempt, and I'll have a chat with my surgeons. And if I think there's a lead point when I'm doing the ultrasound, you can have a discussion with your surgeon. Some would still like you to try because, like I said, you've pushed it round as far as you can, and then it makes their operation easier, or some will take them straight to theatre. It's just a conversation to have with them. So I don't think any of these videos are going to work, so I'll show you this case at the end. So I'm just going to skip through these slides because these videos won't work. But it's a case where we had a recurrent intussusception, which I'll show you at the end. Oh wait, that video worked. How weird. Okay, anyways. So candidate 4, do you want to go on to this case?
Yeah. Okay, again, select the ultrasound images. Okay, I can see on the right side, there's a blind-ended tubular structure with alternating hyper and hypoechoic muscular bands.
Mm-hmm.
I think this, and on the left side, top left, is the transverse image of the previously mentioned tubular structure. I think this represent appendix.
Yeah.
The diameter is 0.9 cm, which is thickened. So there's appendicular increased vascularity. Mm-hmm. So I think present acute appendicitis.
Okay. Perfect. So those are all correct findings. So this is your blind ending tubular structure, which is the appendix. It's not, I've not labeled the images very well for you, but this is in the right iliac fossa. You can also see that there's increased echogenicity of the surrounding fat. So take my word for it or see it. There is this fat around the appendix, the periappendiceal fat, is too bright. And then once we've measured it, it's above 6 millimeters, so it's nearly 10 millimeters, and there's increased vascularity, all features suggestive of acute appendicitis. So a normal appendix, so this is a picture of what the appendix should normally look like, is under 6 millimeters in diameter, so that's best measured on the transverse view. It's normally compressible, so you should be able to squash the appendix, and it's often got gas within it. And there is normally minimal to no vascularity around, minimal vascularity around the appendix and within the mesentery. And the surrounding structures are normally also okay. To find the appendix, what you should do, and what I do, is I trace down my right hemicolon to my cecal pole. And then I look for my ileocecal valve so I can see my terminal ileum, make sure that's all normal and not the cause of their symptoms. And then at the bottom of my cecal pole, I should see my appendix coming off, arising from there. So this is an image to show you your cecum. This is, and this is your appendix coming off here. And normally the appendix is draped over the iliac vessels if it's in its normal position. So this will be your iliac vein, and you'll see your iliac artery, and you'll see the appendix just drapes over them. And then I normally just make sure there's nothing sat between the appendix and the psoas that could suggest a little abscess, and then do all my measurements. If I'm really struggling to see the appendix, I do a couple of things. So I try and press harder or less hard, because if it's compressible, you might be squashing it, or you might not be moving the bowel gas around enough to see the appendix. So just change your pressure. I also get my patient to go decubitus and try and do bimanual compression, so one hand on their back and the probe on their front of the abdomen to try and move that bowel gas out of the way so I can see the appendix. And then sometimes I'll also get them to go and empty their bladder, because that moves things around, and then I can see if I can see the appendix as well. So lots of different tips and tricks you can try and find your appendix. When you found your appendix, if it's an appendicitis, you'll see that it's more than 7 millimeters in diameter, which you can see in this case. You won't be able to compress it. It'll be hypervascular, like we saw on the initial case, and it won't move. It'll be in a fixed position. And I find that if I can find the appendix really easily, so sometimes even with my curvilinear probe, if I'm just having a look in the pelvis and I see the appendix, it's more likely to be inflamed than not inflamed. And then you look for your surrounding changes in the right iliac fossa. So increased echogenicity of your mesenteric fat, which is due to edema and inflammation, any free fluid, any mesenteric lymph nodes that are reactive, and also look for any collections or features of perforation. And you need to be able to follow the appendix from the base all the way to the tip to be sure that it's completely normal. And if it's thickened, you want to follow it from the base of the tip to look for any disruption of the wall, which might suggest it's perforated. On the transverse image, this is called a target sign. So this is, you get a hypoechoic fluid-filled center of your appendix, and then you get your inner mucosal, submucosal ring, which are also hyperechoic, and then right around the outside is your hypoechoic area. So this is called your target sign, and then you'll see there'll be a halo of mesenteric fat around the appendix that's echogenic. Okay, so this is another example of a dilated appendix. You can see here it's fluid filled and it's got these alternating echogenicities. And like I said, it drapes over the iliac vessels if it's in its normal position. This is an example of a perforated appendix. So this is the appendix here. And remember what I was saying about following it from the base to the tip. So the base is up here and it looks normal. And if you just saw this bit, you would call it a normal appendix. But as we come down to the tip, you lose that integrity of the appendix. You lose the definition of the wall. And you can't really, if I ask you to point to the tip of the appendix, I think it would be a challenge. And then just at the tip, we now see this hyperechoic structure with posterior acoustic shadowing, which is in keeping with a fecalith, and that there is no appendiceal wall around this, suggesting that this is a perforation and the appendicolith is within the mesentery. And you can see that this fat around this area is very hyperechoic, in keeping with peritonitis. Okay, this is another example of a perforation. So here you can see we've got lots of echogenic fat. We've got fluid tracking through the mesentery with a fecalith. And then we've got reactive thickening of the surrounding bowel. So this is ileum that's thickened. And then this is a bit of sigmoid that's thickened as well. And then this patient actually also had a small bowel ileus. So they had dilated fluid-filled bowel loops that were a bit thick-walled. And that was in reaction to all the inflammatory change that was surrounding that pelvis because of this perforated appendix. You can also get a retrocecal appendix. So that's where the appendix goes up and it goes towards the tip of the liver rather than going down into the pelvis. And that's why if I don't see the appendix in the pelvis, I will scan back up towards the liver to make sure I'm not missing any suggestion of a retrocecal appendix. So this patient actually had a collection by the tip of the liver. So this is a complex collection and abscess. And then as we scrolled through, we found the fecalith within it. And then this is all inflamed mesentery around and dilated bowel loops with an ileus. And they went on to have a CT because initially we weren't sure if it was due to the appendix. We weren't sure what was going on, and to get some more information for the surgeons. And I can't show you the CT because my videos aren't working, but the CT demonstrated a perforated appendix with a retrocecal, with a collection due to a retrocecal appendix. But you could actually see the collection better on the ultrasound than you could on the CT, which we'll show you when Sam lets me use her slides. And this is just to show you more of that collection down there with the fecalith. So moving on from appendixes, we're going to go through a few more cases. So candidate 4, do you want to go through?
Sure. So this is a frontal radiograph of the abdominal X-ray of a pediatric patient. I can see two oval shape rounded metallic density at I think it's in the stomach. So they are not stick to each other, and the shape. There's no sign of pneumoperitoneum. Yeah, and the visualized bones and lungs are clear. So I think this is a foreign body ingestion in the child. Highly suspicious. These are batteries.
Yeah, exactly. Go on.
Yep. I mean button batteries. This is surgical emergency. I would inform these findings to the surgeon, and might need to remove it. Yeah.
Exactly. So these are ingested button batteries. So we've got two radiopaque foreign bodies, as candidate 4 has said, and I actually think they're within the distal transverse colon. I think this is stomach up here. Oh, my pointer's not working again. Don't know why that's not working. So I actually think they're within the stomach. So this is, within the colon. So this is stomach up here, and then this is colon. And important negatives, like you said, are to look for any features of pneumoperitoneum to suggest perforation. And then I also look for any bowel obstruction as well. But this is a non-specific bowel gas pattern. So things that children can ingest include button batteries, they can ingest magnets. And in the UK, we've actually recently changed in the last year, we changed our imaging protocol for magnets. So we used to do just an abdominal radiograph initially and a chest radiograph if you saw nothing on the abdominal radiograph, but we're concerned that they'd ingested a foreign body just to see where it was. And then if we saw a single ingested magnet on the radiograph, we would then do a lateral of the abdomen to look to see if there's multiple magnets, because you can get magnets that stick to each other and look like one single magnet on the imaging. So doing the lateral confirms whether you have multiple or a single magnet. And then because magnets like to attract each other, they try and join through the bowel wall, and they can lead to perforations. So it's important that you identify if there's more than one magnet, because it changes how they manage the patient. So X-rays are the first line imaging for foreign bodies. Some people do them as low dose fluoroscopy imaging. Some people do a proper radiograph. I personally prefer a proper radiograph for the initial X-ray, but it depends on your practice locally. And what you're looking for is a radio opacity or radio density that looks foreign, basically. So screws, magnets, anything that children can get their hands on, they seem to want to swallow. Coins is also a common one we see. And they can be anywhere within the respiratory and the GI tract. So if there's a very strong suspicion of a foreign body, you have to go hunting for it. So if the initial radiograph of the chest or abdomen is negative, then do a radiograph of the other part of the body just to see if you can find a foreign body. Signs, so this is someone who swallowed a screw and it's down in their right main bronchus. Features that might suggest to you that there is a foreign body, but you can't actually see it, so it's not radio opaque, are on a chest X-ray, you can see air trapping. So basically what you'll get is a hyperinflated lung or part or lobe of the lung, and that will look more radiolucent than the other lung, because you've got air can go in, but it can't escape, so you've got air trapping within that lung. So if you ever see a hyperlucent hemithorax in a pediatric patient in particular, you have to raise the concern, the possibility of a foreign body, even if you don't see a radiopaque density. There are other different conditions that can give you a hyperlucent hemithorax, such as Swyer-Johnson, but foreign body probably is the one we see most commonly. And the reason that the item may not be radiopaque is that if it's something like food, like a peanut or a grape, that you won't necessarily see on the radiograph. So just to be aware of these findings. And then when the foreign body's in the GI tract, it can be difficult to say exactly where it is. So I normally say it's projected intraluminally within the left upper quadrant or right lower quadrant, wherever it is, unless I'm sure it's definitely in that structure. And then depending on the foreign body, we may do serial radiographs to make sure that it passes through the GI tract. So this patient actually was one of those ones. So she swallowed 4 batteries. So these are AA batteries in the UK. So she swallowed 4 of them and was having serial x-rays to look for them moving on. So you could see they were initially together, 4 of them at the right iliac fossa. And then on her subsequent radiograph, things had moved on. So we actually found out there was actually 5 because the 4 were obscuring the 5th battery, and 1 had progressed into the ascending colon and 3 were in the transverse colon, but 1 stayed within that right iliac fossa and looked like it was more inferior than it had been on the prior radiograph. If I just flick back for you. So she had a subsequent x-ray, which I've not shown you, which also showed that this battery here was not moving. It was just staying stuck here, and she was clinically deteriorating with worsening abdominal pain and fevers. So she went on to have a CT, which I can't show you, unfortunately, the video, but this is that battery here. This one is actually here, and it's actually perforated through the bowel and ended up in an extraluminal position. And you can see that she's got pneumoperitoneum in the abdomen secondary to this. So she actually perforated. And normally with AA batteries, we don't tend to worry about them in the UK. We just watch them for them to pass. But they can erode through, as we can see in this case. So this, I think, are my final cases. So candidate 4, do you want to have a go at this case?
Yeah, sure. These are to select the frontal radiograph of a neonate. For left, I can see multiple lines. And
Are you going to have a go at the lines for me, please?
there are some lateral cardiac lines, which are at the left apex and also at the right parasternal area. And then 1 line at the midline, up from the cervical spine until the lumbar spine. I am not very sure what line is this.
Okay. What do you think it's going to? So what line would you expect to go down the midline from the pharynx, down the midline across the diaphragm?
An EVD line, extraventricular drainage. I mean, for the...
No, just a common line we put in neonates.
Yeah.
So this is an NG tube?
Yeah.
Yeah.
NG tube.
So this is an NG tube.
Okay, so
within the stomach.
Okay, so so if it's in the stomach, this would be a very distended stomach.
Yeah.
So other than that, I can see. I think there is a sign of pneumoperitoneum, because I think there is a football sign in the abdomen.
Okay. What makes you think there's a? Describe where you're seeing it for me.
Because I think there's a lucency overlying the liver, so left lumbar region. So it somehow, I think it is comprised. It shows a football sign. Other findings. I can see some lucencies in the lower abdomen, which could represent a clump of bowel loops, and also is.
Which side of the lower abdomen are you seeing those?
On pelvic and as well as the right lumbar region.
So here?
Yeah, this area.
Okay, so this is the stomach.
Oh, this is the stomach.
Because it's got the NG tube in it.
Okay. I don't see, other than the stomach gas, I don't see any bowel gas in the abdomen. There's a lack of rectal gas as well. And okay. So maybe the stomach seems continuous with the structure on the right side of the abdomen, which could be externally from the this patient's abdomen. Yeah. So
what do you think is going on?
I think the bowel loops is extruded from the abdomen.
Exactly.
So this and follow the
gastroschisis.
Gastroschisis.
Sorry. Yeah.
So,
okay. So I think it is quite a confusing radiograph, and you kind of have to, if you've never seen one before, you have to really think about what you're looking at. So the first clue, I'm going to come back to that. What I'm going to say is on this one, you can see that this child has right upper lobe collapse, and I think it's because the NG is a little bit low, and then they've pulled it back, and that lung bit of lung is reinflated. So that's why your lines and tubes are important. But then the next clue for something not quite right going on is this NG tube. So normally we're used to our NG tube coming down the midline, bisecting the carina, which it does here. So it follows the course of the esophagus, it bisects the diaphragm, and then it normally comes to the left upper quadrant. But here you can see it's abnormally located, and it keeps coming down the midline, and the gastric bubble is abnormally located. So that suggests that the stomach is not where we would expect it to be. And then here we've got all this abnormal opacity with some areas of lucency, as you described, which represents the extruded abdominal contents. So this is a gastroschisis or an omphaloceal, but often we can't tell the difference on imaging unless we know it from the antenatal diagnosis or from when the child is born. But yeah, so this is herniated bowel wall contents through a defect in the abdominal wall. So gastroschisis is normally affects the bowel, and it's rarer to have the stomach and the bowel and the liver, also herniated through, unlike an omphaloceal where you often get herniation of the liver primarily with or without bowel. So the gastroschisis herniates into the amniotic cavity because there's a defect in the paraumbilical region, the abdominal wall. And the difference between that and an omphaloceal is where the defect is. So the omphaloceal defect tends to be at the base of where the umbilical cord inserts, whereas the gastroschisis tends to be paraumbilical. And then the gastroschisis tends to have no peritoneal membrane around it, whereas the omphaloceal does have a peritoneal membrane. But we often can't tell the difference between these two things on imaging. So we rely on our antenatal diagnosis and the surgeons. So it normally, the defect's more often on the right than the left, but that's by the by for us when we're looking at imaging. But there are associated anomalies, primarily with omphaloceals, that we have to consider because they tend to be associated with abnormal chromosomal conditions or syndromic conditions, and you can get multiple organs being affected, so like kidneys, cardiac, etc., etc. Whereas with the gastroschisis, abnormalities are rare, but they mainly, if they do occur, they affect the bowel, so, because the bowel is the primary organ that herniates. So you'll get intestinal atresias. You can often get malrotation with both conditions, or you might get some stenosis of the bowel because you've had vascular compromise and areas of necrosis. If the peritoneal membrane ruptures on a omphaloceal, it's difficult clinically to differentiate that from a gastroschisis. So you might look at what contents have herniated through, basically. So this is a gastroschisis, and then this is an omphaloceal. So this, you might say, looks like it's more contained, more globular. So you might think that there's a membrane holding everything together, which points you to an omphaloceal. But generally, our clinical teams have already decided what it is, and we just say there's herniated bowel contents. And here you can see all the bowel that's come through. So that was quite a lot of acute abdominal presentations / some not so acute that we've covered. So well done, candidates 3 and 4. So we've had esophageal atresia with tracheoesophageal fistulas, and we've looked at Rapolko tubes, which is the double lumen blind ending tubes that's put into the proximal esophagus to help drain it. We've talked about factorial associations, so vertebral body anomalies, anorectal malformations, cardiac anomalies, tracheoesophageal fistula, esophageal atresia, renal anomalies, and limb anomalies, with it being important that you review the initial radiographs to look for the vertebral body anomalies, the cardiac anomalies, and the limb anomalies, as well as identifying the esophageal atresia and the tracheoesophageal fistula if one is present. And then they'll go on to have renal ultrasound to look for the renal malformations, and the anal rectal malformation should be diagnosed clinically. We've talked about necrotizing enterocolitis, so we're looking for non-specific signs on radiographs, which include dilated thick-walled bowel loops or non-changing bowel gas patterns or distended bowel loops, as well as more specific signs, which are pneumatosis intestinalis, portal venous gas on the plain film, and pneumoperitoneum. And also the importance of the use of ultrasound in necrotizing enterocolitis, primarily for follow-up rather than diagnostic imaging, and it having similar features as we see on the radiograph. Pneumoperitoneum, looking at all the different signs on a supine abdomen, which include football sign, which is air beneath the anterior abdominal wall, wriggler sign, which is where you see both sides of the bowel wall due to gas being on either side, continuous diaphragm sign, which is where you get gas in the upper abdomen outlining the diaphragm, and outlining of the peritoneal ligaments such as the falciform ligament, as well as triangular pockets of gas. If you ever see a triangular pocket of gas, it's not bowel. Be suspicious for pneumoperitoneum. We've talked about foreign pyloric stenosis as well, with the single muscle wall thickness more than 3 millimeters being the most crucial. And to answer the question earlier, the diameter should be less than 14 millimeters. I've double checked it whilst I was doing this presentation. It's less than 14 millimeters, because the single muscle wall is not the only bit that contributes to the diameter. So you've got the different layers of the wall outside of the muscle, plus you've got the channel in between the two walls. So it should be less than 14 millimeters. And then we talked about the target sign as well on the transverse ultrasound. We've talked about interception, and I'll try and show you those videos if we get some time at the end. Looking to see if we can find a lead point which will make reduction more difficult and may necessitate surgery. And then acute appendicitis, so looking for any complications of appendicitis such as perforation, collections, and appendiceal masses. Sorry, I didn't really talk about appendiceal masses. They're just basically really inflamed mesenteric fat, and then you see stuff stuck down to it. So you might get the appendix stuck down. You might see the surrounding bowel loops also stuck down, and it just looks like a big inflammatory mass that's got increased vascularity, but there's no collection component to it. And both collections and appendiceal masses tend to be managed conservatively in my trust. And then we've looked at anterior abdominal wall defects. So the radiographs aren't to diagnose gastroschisis or Montfleury. That's where you diagnose clinically. The radiographs are to look for any bowel dilatation, which you can see if there's a concurrent atresia or there's been a stenosis. And then they're also to just, often they've put lines into the patient, so we're doing it to look at the lines. And not often they'll have already repaired it before they've even done the initial radiograph, but those were just some good cases to show you if you've not seen them before, because they could come up in exams. All right, I've been talking for ages.
And also there's one more thing. So in gastroschisis, because it's just bowel, right? Often, I think one of the pictures that Toby has, they also put what we call a silo. So it's just a plastic covering over that's the case, which can make it hard to differentiate between omphalocele. Of course, you can also look for what's herniated within. So if you've got more gas-filled bowel loops, there's a bit of bowel, and omphalocele, there's a bit of liver. So it can be easily said, there might be something else other than bowel. The other thing that they might want you to do is to do an ultrasound and see exactly what's herniated, and you can help to characterize it further.
Oh, I've never had to do an ultrasound, so that must be a Sam thing. Okay, final few slides. I might just talk through these because I think it's I've run out of candidates, and it might just make things a little bit quicker because we're coming to the end. So we've got 2 liver cases to show you. So neonatal jaundice is complex. There can be lots of different causes, but one of the causes can be biliary atresia. And basically there are 2 key signs that we look for when we're assessing for biliary atresia. Number 1, you have to make sure before you start anything that the patient is well fasted. So we want at least a 4 to 6 hour fast for the patient, because gallbladder assessment is really important. So the first thing we're looking for is the triangular cord sign. So this is at the division of the portal vein. So I normally look along the right main portal vein, and we're looking to see if you can see a hyperechogenic structure, So normally there is a bit of hyperechogenicity, but if it's more than 4 millimeters, then that suggests that you've got a true triangular cord sign, and basically that's due to the atretic ducts that occur in biliary atresia. That's what you're seeing, the fibrotic atretic ducts alongside the portal vein. So this is the most specific sign for biliary atresia, the triangular cord sign. The other signs that complement the diagnosis are if your gallbladder is abnormal. So you can either get an absent gallbladder, you can get a small gallbladder, you can get an irregular gallbladder. If it's less than 2 centimeters in length, then that suggests that your gallbladder is small. And this has to be on a well-fasted child. And if you see any irregularity of the gallbladder as well, then that suggests that your gallbladder is abnormal, which ties in with the diagnosis of biliary atresia. And then this picture just shows you the triangular cord sign on a transverse image, but I normally measure it on another transverse image, which is where I normally measure it. So biliary atresia is a congenital absence or severe deficiency of the extrahepatic biliary duct. So often it's non-syndromic, so it's just an isolated atresia of the bile ducts, not related to any other conditions, but it can be syndromic, causing lots of congenital anomalies such as polysplenia or asplenia. They can get heterotaxy, which feeds into the polysplenia, and then they can get intestinal malrotation and interrupted IVCs and things like that. And the most common presentation is a conjugated hyperbilirubinemia. Sorry, I always struggle to pronounce that word. So they get conjugated raised bilirubin rather than unconjugated, and the concern is that they've got biliary atresia, and we need to pick it up as early as possible so they can go on to have the Kasai procedure, which prevents them going on to develop cirrhosis. So ultrasound is the first line imaging, as I've said, and we're looking for those atretic fibrotic ducts, bile ducts, which is the triangular cord sign, and we're looking for the abnormality of the gallbladder. So often with biliary atresia, with biliary atresia, you do not get intrahepatic duct dilatation. So if you have intrahepatic duct dilatation, then it's unlikely to be biliary atresia. And if you are concerned for biliary atresia based on the ultrasound appearances, you can do a HIDA scan, which is a nuclear medicine scan, which looks for uptake of the radiotracer and then excretion into the gallbladder and then eventually into the small bowel within 24 hours. But the definitive diagnosis is done by a biopsy. So if it's picked up early enough, they can have this thing called a Kasai procedure, which is where they do excision of all the fibrotic abnormal bile duct tissue and then do a Roux-en-Y anastomosis of the intrahepatic ducts to lead to the jejunum. So that's how you get your biliary drainage, basically via this Roux-en-Y jejunostomy. If it's caught late, or if the patient goes on to develop cirrhosis and ends up in liver failure, then they can end up needing a transplant, and it's the most common cause of transplantation in the UK and in pediatric patients is biliary atresia. So this is just a bit more about your gallbladder ghost triad. So you get a small gallbladder, so less than 2 centimeters is what I have in my head. And you get irregularity, which is due to thinning or absence of the echogenic mucosal lining. So you get irregularity, and then you also get thinning or absence of the echogenic mucosal lining. So you can see here we've got a very small gallbladder. It's really irregular, and you don't see that mucosal lining as well. And then if we compare it to a normal gallbladder, you can see it's not irregular, and you can see that mucosal lining very well, as you can see in these pictures. So this is your gallbladder ghost triad. Other features that you can see on ultrasound are you can see a dominant hepatic artery, because that is the main supply to the bile ducts. And then you get hypertrophy of the hepatic artery, and it becomes the dominant. So you might think it's the portal vein because it's so big. And then this just shows you a HIDA scan. This shows you an MRC. This image, we're moving on, shows an MRCP study, which shows a colodocal cyst. So this is a dilated CBD, and this is your gallbladder, and this is your cystic duct, and this is abnormally dilated. So in a pediatric patient, I normally have up to 2 millimeters as my cutoff for normal caliber CBD. I allow up to 3 in the teenage children, but about 2 is my cutoff for normal CBD. And you can see Here, this is just further MR images to show. So this is the gallbladder here, and then this is that dilated common bile duct. So colodocal cysts, there's 5 different types, and the one we saw on the previous imaging was the type 1, where you've got dilatation of the common bile duct, and it's based on a Todani classification, which is a little bit controversial because the surgical literature says it may not accurately define the different types and the different disease processes that are going on, but this is the one we still commonly use in imaging. So you can have type 1, which, like I said, is the common bile duct. You can have type 2, which involves your cystic duct, and then depending on the involvement of your intrahepatic ducts, can upstage you into type 4 or type 5. 60% of colodocal cysts are diagnosed in the pediatric population, particularly under the age of 10, although it can be asymptomatic and you can be diagnosed as an adult. It can be associated with biliary atresia and hepatic fibrosis, which tends to be the type 5, where you get intra and extrahepatic duct dilatation. The exact etiology is uncertain, so no one knows the pathophysiology behind colodocal cysts, but they're just the other cause of neonatal jaundice to be aware of. And like we would see on the MR, what you see is a dilated bile duct or cystic lesion that communicates with the bile duct and is separate from the gallbladder. And then they'd go on to have MR imaging to clarify the anatomy prior to surgical management. So those were 2 quick liver conditions, just so that you're aware of them. So biliary atresia and colodocal cysts, which cause neonatal or childhood jaundice. Biliary atresia, the 2 key features are triangular cord sign and gallbladder ghost triad on ultrasound, with HIDA scan as a supportive examination, but biopsy being the definitive medium to make the diagnosis. And then a colodocal cyst is due to a dilated cystic lesion communicating with the biliary tree, which is separate from the gallbladder on ultrasound and cross-sectional imaging. So I think that's the end of the session. Sorry, that was a lot to get through. Session 2 was, part 2 was a lot longer than part 1, but I'm just going to quickly go through the questions and flick back through the slides. I did try and answer most of them as I went through, so we'll just go back.
Toby, do you want me to share my slides so I can show them the videos?
Yeah, if that's okay. If I stop sharing.
Yeah.
This study is looking for a H-type fistula. So what we do is, this is the way I do it. We do like an esophagram. So you have your NG tube in the esophagus, and then you inject contrast into the esophagus. And what I do is similar to how I do my anastomotic leak ones post-repair, is I gently pull back on my NG tube as I'm injecting contrast and see if I can see any contrast going into the trachea. And I do them in a right lateral position to try, or slightly oblique, to try and lift the trachea off the esophagus. And then what you're looking for is a little fistulous tract, and then contrast pacifying the trachea, which it shouldn't normally do. You have to be careful not to pull your NG tube too far back, because you can end up in the pharynx and then they're aspirating, and that's why you're outlining your trachea. But that's how I do them. Do you do them any differently, Sam?
No, I think in my trust we don't do tube esophagams, so we just do a routine swallow, because the surgeons say that. Yeah, and the reason why I think unless it's a very big defect, then they will be worried, and that's the reason for the tube esophagram, because you want to give enough pressure, because some small tracts can be opacified with a normal swallow, because the pressure is not high enough. So which is why you want direct injection of pressure. Yeah.
So I think we do them in the recurrent aspirations, chest infections, the ones where we're looking for a really small tract. We'll do a tube esophagram, as Sam has suggested. Okay, would I prefer use of diluted barium over water-soluble contrast media to evaluate postoperative TOF? Nope, I would still use water-soluble contrast media. A lot of these kids haven't eaten, so there's a risk of aspiration. They've had an a Rapolgal tube since birth. Post-repair, they've had an NG tube. Their swallow mechanism hasn't really been tested. I would still use a water-soluble contrast media. And also, if you get an anastomotic leak, it's less irritable using water-soluble contrast than barium to the surrounding structures. So can you go to the NEC X-ray, please?
Yeah, sure.
The first one.
Yep.
So it's quite subtle. and we can't window, but this, as Sam is pointing out, is the area of abnormality. So if you look at the wall of the bowel, you just get the impression that there's more bowel wall there than there is when you look at other loops, which suggests that the bowel wall is thickened. It's quite a subtle abnormality, and you'll pick it up the more you look at neonatal radiographs and what to expect and what to see. I think I did highlight the pneumoperitoneum, so I'm going to skip that question and skip the sign in the previous ones. And I've answered that question about the catheter, and we've done the pyloric stenosis question. Okay, so when I do ultrasound for pyloric stenosis, I image them supine. I do all my imaging supine. Some people will put them in a left lateral decubitus position to try and see the stomach better. Left lateral? Do I mean left lateral? In a
right lateral.
Right lateral decubitus. That's why I paused. I was like, that makes no sense. In a right lateral decubitus position to try and see the pylorus better. But also what it does is it tends to encourage the stomach to empty, similar to what we do in an upper GI contrast study, putting them in the right lateral position. But I tend to do mine supine because I find I can see what I need to see supine. When should we give pylorospasm as a differential diagnosis? I would suggest any ones where the pylorus looks at where it's starting to measure at the upper limit of normal for single wall thickness. So once it's getting over 2.5, coming to 3 millimeters, I would suggest that it's, because it's not abnormal enough to call it a definite pyloric stenosis. But what I would do is in my report, I would say this is measuring towards the upper limit of normal, and I've not seen, if I've seen the pylorus open, that's fine, it's normal, the pylorus open, move on. If I've not seen the pylorus open, I'll say this is towards the upper limit of normal. I've not seen the pylorus open, we should follow this up. So I'd repeat the imaging in a few days and just have another look to see, because if it's pylorospasm, I shouldn't see an abnormal pylorus again on the second ultrasound. If it's up towards the upper,
No, sorry, I was just going to say also, just remember that these measurements are arbitrary because you don't know when people came out with these terms. Were they done in term babies? Were they done in preterm babies? You know, everyone's, we know that I think if they've got higher body weight, or that's what literature says, then your measurements can also change because they'll be thicker to account for it. So let's say you've got a very premature baby and you're trying to use these measurements, they can actually have pyloric stenosis even though they don't meet these measurements. So it's really a dynamic examination rather than the measurements this, it is definitely this kind of thing. Yeah,
so definitely you have to watch to see if that pylorus opens. And we get referred stuff from around the region where people haven't seen if the pylorus opens or not, and often we're repeating the imaging to see does the pylorus open. Often when you see the pyloric stenosis, the stomach's really distended and you'll see the stomach contracting, but nothing will happen at the pylorus, which adds confidence that it's a true pyloric stenosis. And I find that we're diagnosing it younger and younger now. So it used to be 6 weeks was the typical age of presentation, and now we're doing it in 2-week-olds. So like Sam said, you have to look for that dynamic assessment. So I've done contraindications. How I find the appendix, so I do graded compression. So I keep the probe, I use a linear high frequency probe. I do graded compression down the right side of the abdomen, so down the ascending colon until I find the cecum. And I try and, instead of lifting my probe on and off the patient, I try and keep the pressure there, because if they're peritonitic, lifting it on and off is going to irritate them and they're not going to want you to scan them. So I keep my probe in the same position and I just gently move it down the abdomen, keeping a good pressure, trying to dispel those bowel loops. I might stay in one position for a little bit of time to try and encourage the bowel to dispel, the bowel gas to dispel away. And then I'll move my probe down, find my cecal pole as my anatomical landmark. Go forwards 2 slides for me, Sam, maybe 3 to show the anatomy. Find my cecal pole as my landmark, and then I will look for my ileocecal valve because I always check my terminal ileum in all these patients. And then just inferior to that, you should see your appendix draping over your psoas and your iliac veins and artery. And then it should be blind ending. Some of them can be quite long, so just make sure you follow it all the way from the base to the tip. And if you can't see it all, put that in your report, because calling an appendix normal without seeing the whole appendix can mean that you're missing an appendicitis. If I can't see it doing that, then I'll do either turn the patient obliquely, do bimanual compression, or get them to empty their bladder. Those are the little things I do on top. where else are we? I'm losing track of all the questions. Okay. Yep. Repulsor tube is just it's a double lumen tube that they put in so they can drain the esophagus. So I think we've got a picture on maybe the second case. Keep going. There, that's the repulsor tube. So you can tell it's a repulsor tube because it's got the interrupted radio dense lines. So they're interrupted. So you've got a hole between them. And it means that they can aspirate and also they can put saline in as well. So it's double lumen. So they can suction from it to drain the secretions that the child has swallowed. But they can also inject into it as well by putting some saline in. And the saline helps break up the secretion so that they can then aspirate them. So we've done that. Done the first NEC X-ray. In HIDA, how can you differentiate between neonatal hepatitis and biliary atresia? Didn't we have this conversation? I think I had this conversation with my regis yesterday. So it can be very difficult and you can't necessarily differentiate between them on HIDA scans, and that's why biopsy is the definitive diagnosis. So if the HIDA scan is abnormal, in that you don't see any excretion of the radiotracer into the bowel after 24 hours, I would normally just say the HIDA scan is abnormal. The differential for this is this, this, and this. Particularly, for example, if they're on TPN, total parenteral nutrition, that can give you an abnormal HIDA scan, and then they have to make the decision whether they need to send this child to a liver center for biopsy. So you can't necessarily differentiate between the two on the HIDA scan. And which contrast is given in H-type fistulas? Omnipaque, water-soluble omnipaque is given, or other water-soluble contrast. So I think those are all the questions.
Do you want me to do the videos?
Just now, we've only got 3 minutes, so maybe we'll just leave it. What do you think, Dr. Khan?
Sure. Oh, I just show it since we are here. It's quite fun to show the video.
I think Sam, go ahead.
Go ahead. Okay.
Yeah, go ahead.
All right. So I'll tell you.
So, first one.
Yeah. So this is an interception. So this is just a video. I love taking videos. I love cine loops. I know Sam loves cine loops.
Yeah.
I find that especially now I'm a consultant, I'm trying to review a registrar's ultrasound. Sometimes I'm like, I don't know what you're looking at. But if they've sent me a video of what they think is abnormal, I can easier dismiss or confirm the abnormality. And I take videos for myself because sometimes you've not noticed something as you've been scanning, and then when you go report it, you see the video and you see the abnormality. So this just shows you an interception. So you can see this is in a transverse view, and you can see that you've got the large bowel here, and then the pulled in small bowel, and then you can see the echogenic mesentery in between the two layers. And then if you scroll through the video,
yeah, once again, we need to start it again. Yeah.
And then you can see the little lymph nodes, which are likely the lead point going into the interception. And I think that's it, really. It's just a nice video that shows it all the way through.
Next one is this one, the reduction one.
Okay, so so this is a reduction. It goes very quickly. So we'll just play it a couple of times. So this is the catheter into the rectum, this line here, which Sam may show.
Yeah.
And then this patient is supine, so, this patient is prone, so we're seeing gas opacifying the rectum and the sigmoid, and you can see that there's a filling defect. If you go back to the
once again.
So the filling defect here is your interception mass, and you can see it's in the transverse colon, and then it's been pushed round as we're insufflating the bowel with air. It's been pushed round. This is someone's hand because they're trying to hold the child still. And it's been pushed down and round into the hepatic flexure now. We're coming down into the ascending colon and into the cecum, and then we're pacifying small bowel loops, which shows that we've successfully reduced the interception. We do ours under sedation, so we give oromorph or oral sedation to try and make the child calm, and we only do it in children, in very young children. Anyone who won't who's too big or won't react to the sedation, we don't do it. So I think our cutoff is about 2 to 3 years old. Okay, so this was the case that I wanted to show you. So this child presented with an interception, classical history, saw it on ultrasound, confirmed it was all the way to the left upper quadrant by the time we scanned it. Often we just see them at the right upper quadrant by the liver. but this had gone along the transverse colon as well. We did the reduction.
Sorry, Toby. These two don't seem to play on mine either. So apologies for that. I think there's something.
Okay.
Sorry about.
Fine.
Yeah.
So we did the reduction, and it was reduced really nicely, and the child went home. They represented, I think, a week later with another interception, and we know 10% of them can recur. So we did the ultrasound, saw another interception, redid the reduction, but on the second reduction, as you follow it through, so the child is prone again, you can see that we're reducing it. You can see this filling defect, and you'll see it go into the, and then we're pacifying the small bowel loop centrally, but we still have a filling defect within the cecum. So there's still an area of abnormality within the cecum. So is this the potential lead point, and that's what's caused this child to represent with their interception? So there's the small bowel loops are pacified, and then we've got this filling defect that persists. And if it's a true reduction, you shouldn't have any persisting filling defects. So we go on to do an ultrasound. So if you go to the next slide, does that play? That might not play.
Wait. Oh, this is the one that plays. No, doesn't play.
Okay.
Don't know why.
So this is just the filling defect, and I've got some static images, and this child ended up having a colonic polyp. So this is the polyp seen within the cecum with increased vascularity, and that was the diagnosis, and that was their lead point. And interestingly, they'd actually been sent home after the second one because the surgeons didn't believe us that there was a lead point, and then they wanted a follow-up ultrasound, and on the day of the follow-up ultrasound, she had another interception, but was asymptomatic. And then that's when we identified the polyp as the lead point. And then she had to go to theatre to have that polyp resected and to have her interception reduced. So that's it. Those are all the cases. Thank you very much. It's been a long session, but hopefully you've learned some things and found it useful going forward. And if you could please fill in the feedback form, because we've got 3 more of these sessions to do, and we can make some changes prior to the other 3, then that would be great. Thank you so much.
Thank you very much, Toby and Sam. Brilliant, absolutely brilliant. Some of these cases, have rekindled my love for pediatric radiology. Maybe I should now do it once again. So beautiful cases. And a beautiful comment I received from, your candidate for him, this is 5 a.m. in morning. Can you imagine? And he says it was worth the sacrifice, so he's learned a lot. So well done.
You did great considering you haven't slept.
Yeah. So thank you very much, and hope all of you will join us next week. The feedback QR code is there. So please, those of you who have joined us first time, please remember that you will not get a feedback form. You will not get a certificate, CPD certificate, unless you fill in a feedback form. And thank you very much once again, Toby and Sam. Thank you.